There are 6 physicians in our group. We have a staff of about 65 that supports them. Our physicians have over 9 decades of combined experience. We've been voted 7 times, which is the highest number that any practice has been voted top doctor in our specialty, and we're a U.S. News & World Report top doctor. I'm just going to tell a little about us, just a little bit of foundation, and then we'll spend the overall majority of our time on the topic. Our locations, and also Barrington Pain and Spine Institute right now is the only ambulatory surgery center in the state of Illinois that is totally dedicated to spine care. We don't do anything except related to spine care, whether it's injections or open surgery. So that opened a few years back. It's located in Barrington. We have state-of-the-art operating rooms for spine surgery as well as treatment rooms for interventional injections. A full recovery area. Now, going into the topic at hand. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, as described in terms of association. So there's a couple of different kinds of pain. There's acute pain, or post-surgical pain, or after an injury where you have immediate pain. That's not what we're going to talk about today. So what we're going to talk about today is pain that has been around for longer than the immediate period. Let's say you burn your hand or cut your finger, or if you have surgery, or even something more traumatic, there's immediate pain before it stops. We're going to talk about the pain that lingers beyond the normal healing, beyond the normal healing process. So acute pain has a biological purpose, and it resolves as the healing progresses. The pain goes away as you heal. You break a bone, it hurts, it heals, there's no more pain. Now, the pain impulse was described many times by Descartes, who's known for his mathematics. He first drew this diagram where if you stick your toe in a fire, he noticed that there's a signal that probably goes to the brain. And that was the 17th century. We know that, of course, to be still more or less accurate now. The receptors are in the spinal cord and the brain. Now, who knows what this is? Okay, so nobody wants to admit that this is a poppy. Okay, so opium, poppy, one of the first analgesics, right? Number 1 product in Afghanistan, isn't it? I don't know. But anyway, this is what a poppy plant looks like. And of course, morphine, opium, etc. is a pain reliever. What we try to do in our practice, and the interventional pain physicians who are now coming out of training, is not to mask the pain with the pain narcotic. So not with opium or derivative morphine, filled with like oxycodone. And that's where some of the confusion that your colleagues have shared with me, your colleagues that I deal with on a regular basis have shared with me. They're, by and large, many attorneys still view pain management as the last resort. Those attorneys that we work with on a regular basis understand that our practice and some other practices is a first line place to send your patients with a painful condition. And what I mean by that is, if you had chest pain, would you go to a cardiac surgeon or a cardiologist? You would go, of course, to a cardiologist, maybe your internist. But when you need the surgery, you're forced to go to a cardiac surgeon. In the same way, our fellowship has grown, and our training has grown, and data has grown, our role has shifted to one of diagnosing the precise source of the pain, fixing the source of the pain. If that can't be done, referring it to our surgical colleagues, and one of whom was excellent will be here after me. So it's not to mask the pain. So when you think of interventional pain or pain clinics, please understand that in the state of Illinois, who's licensed to practice pain management? Same people that practice, hey, you're licensed to practice medicine in all of its branches, right? In Illinois, I could practice whatever, and it's legal. So there are those people who perhaps will be doling out high doses of prescription narcotics, and there's practices like ours, which is the largest practice in the Chicago area to treat patients in pain. We don't even get visits anymore from the pharmaceutical reps who sell opiate narcotics. The largest pain practice in the Chicago area no longer gets visits from opiate, pharmaceutical, narcotic representatives. Not because I don't like lasagna and salad and where else, but because we do so few opiates. Because we're trying to address the source of the problem, fix the source. If we can't do it, send it to a surgeon or physical therapy or whatever to address the source. So non-acute pain is what I've been talking about. It's pain that persists beyond the normal course of healing. It can be destructive. People who have post-laminectomy syndrome, people who have complex regional pain syndrome, RSD, it not only affects their life, but who else's life does it affect? Their family. It's a huge issue. Okay, now who knows what this is? This was a method for treating pain a long time ago. This is called trepanation. No longer used, but they would remove part of the skull because they would get rid of the evil tumors, and your pain would decrease. My favorite one is the second one in. Most of these are pretty clean cuts, but that second guy in, he had a few whacks before they got it right, if it wasn't there. But again, it's just interesting throughout history what we have subjected our fellow man to try to relieve her. So most patients want to get better. They're not seeking secondary gain. I don't care if they have a workers' comp case or not. Obviously, there are some that have secondary gain, let's face it. The overwhelming majority do not. If you can fix that patient, get them back to work or their chosen lifestyle, that's what they want to do. They're not wondering, they don't have a quote low pain threshold, and they don't have a personality disorder. We used to have 2 full-time psychologists on our staff. This goes back a while. But as the data got better, and the research got better, and the outcomes got better, what happened was people whose pain was diagnosed, fixed, so they didn't have the pain anymore with substantial use, guess what? Their head got a lot better. So we no longer have psychologists on our staff. Do we use psychologists? Absolutely. Absolutely we use psychologists. We use them prior to putting a spinal cord stimulator in to make sure there's no underlying psychological issues. And we also make sure they have no unrealistic expectations. And also, there are some pains that are systemic. I don't want you to leave here thinking all pain can be diagnosed and fixed and we don't need narcotics. No, there's Crohn's disease. There's diffuse metastatic cancer where we have to do specific things because the pain is throughout the whole body. It's not just 1 or 2 structures. That's not what I'm talking about. Those patients will need opiates and narcotics and other things. I'm talking about the ones where we can identify the structure that's causing the pain. And most patients don't have a mental health. So the causes: muscle, joint, spinal nerve irritation, disc inflammation, nerve damage, scar tissue, right? Everyone here probably has seen someone who's had a surgery, whether it's in the spine or elsewhere. Sometimes the scar tissue can entrap a nerve and cause itself discomfort. So what are our management options? Invasive treatments, physical therapy, medications, implantable pain symptoms, surgery, alternative. Now, when I was in medical school, which is a long time ago at Rush, I wrote a paper that was published on healthcare in China. And at that time, this was the late 70s, acupuncture was very, very popular in China and still is. Right now, if you have, for example, so at that time, if you would have had a herniated disc, you may have had acupuncture as your first line of treatment. And indeed, I received a permit from the to visit some pain clinics in Cuba. So it was legal. I got a government permit. I went down there, and they still treat it that way there. If you go to China now, though, if you go to a medical center in China, they will treat that herniated disc very similar to how we treat it. So for the conditions of the spine that we are seeing, even in China, they're using the techniques we're using, and if that doesn't work, they'll try acupuncture. Now, interventional pain management, I touched on as a distinct medical specialty. When they consult the Illinois Pain Institute, they used to say when they consult an interventional pain physician because I didn't want this lecture to sound self-serving. But a couple of their colleagues who now understand the difference between a pain doctor who's just writing pain narcotics and a pain doctor who's trying to find the source of pain and get them off pain narcotics, said, you've got to put when they consult the Illinois Pain Institute or someone like that. The sooner the better. And the reason is we want to get a precise diagnosis, precise treatment. We want to make sure that while we're doing that diagnosis and treatment, they're not having inadequate pain control. Our role is not to say, no, you're not getting opiates. Our role is to make you comfortable while we're ascertaining the source of your pain. So we do prescribe opiates. It's not that we're opiate phobic, but we're always trying to give a relentless passion for pursuing the source of the pain. If they've had a previous treatment failure, if they've had, for example, a surgery, and they have increased pain after the surgery, or if they have excessive side effects from present treatment. Sometimes we'll get patients referred in with huge doses of narcotics. Doses I've never written in my practice when I graduated medicine in 1982. If the pharmaceutical reps are not visiting our practice, where are they going? Because we know who's the highest per capita user of opiates in the world. Which country? United States. So the United States is the #1 per capita user of opiates per capita in the world. So if they're not coming to our practice, where are they going? They're going to, and they have huge profits, they have huge sales. I'm not saying anything bad about them, I'm just saying these are the facts. They're going to the primary care doctor. Well, God bless them, they have to treat a lot of diseases. They're faced with a patient who's in pain. They've got to do their electronic medical record. They've got 10 patients an hour. They are the highest utilizer of opiates. So we sometimes get patients that are referred to us saying, I don't know what to do with this patient anymore, and we see them on very large doses of opiates. And that's one of our goals, to scale it down and figure out where the source of pain is. So our outcomes, our goal is, as I've said, and I will continue to say throughout this presentation, is to make a diagnosis usually. We usually can't. We can't 100% of the time. Reduce and control the pain, improve their functional ability, get them back to work, get them back to their chosen lifestyle. So let's talk about medications. NSAIDs and COX-2. So the anti-inflammatory medications, ibuprofen, naproxen, Advil, et cetera. The COX-2s, which are gentler on the stomach, Toradol, for example, and you have acetaminophen, but the dosage should not exceed 3,000 milligrams per day because you get liver problems. You should not drink alcohol when you're taking Tylenol because you can have liver damage. Antidepressants. So we don't, although some of these patients have reason to be depressed, there's a substance called serotonin that drops when you have pain for a long time. So we use the antidepressants to pick up that serotonin, and that helps reduce the pain. Anti-seizure drugs. So it's not that we're worried about patients having seizures, but you may have heard of gabapentin, Neurontin, Lyrica, things of that nature. We're not, if you will, the smaller nerves are firing improperly, and instead of a seizure that they're thinking in the brain, these medications work to calm down those nerves that are outside the brain as well, and again, allow them to reduce their narcotic dose. Muscle relaxants, you're familiar, I'm sure, with all of them, Baclofen, Salaxin, Flexeril, etc. Tramadol, otherwise known as Ultram. Tramadol and Vicodin are as strong as one another when you add Tylenol to it. Tramadol does not, the generic Tramadol does not come pre-mixed with Tylenol. So one of the things that we try to do is if we have someone coming in on a high-dose narcotic, we'll use some of these medication regimens. And the last one on the list is narcotics. Hydrocodone, Vicodin, Norflex, oxycodone, Dilaudid, etc. So that's the last one, and that's, in our mind, how we treat it. So there's an increasing number of pain docs. Again, one of the things that I suggest strongly is you ascertain, is this a pain physician that is writing a large dose of narcotics, or is this a pain physician who's trying to figure out the source of the pain? What training have they had? The common goals that we have: identify and treat the disease, control the pain, prevent inappropriate or ineffective medical care, weigh the risks and benefits, right? Informed consent. Let them know that to avoid the red tape, administrative hassles, which in my career has never diminished, probably never will, and hopefully obtain payment services. There are certain trends. The interventional pain physicians now is a growing specialty. More and more people are recognizing the difference between those who are just writing a lot of narcotics to mask the pain and those who are trying to identify the source of the pain. With all the hassles in medicine, one of the most exciting things for me is the advances in our specialty. data, the research that's coming out. It allows me on the first day, as many of you, to see a patient or a client in their worst, right? You probably meet people, I meet people, when they're at a very difficult time in their life. But with the research and data that's now out, it's just wonderful that you do see with your clients, to see them get better. And it's great for me to see it for the patients to get better. And I always know that first visit is typically the worst visit, that I'll see this, the worst condition that I'll see this person in. Thank God. So when pain persists, I mean, how many have had one doctor on the case who's had pain? Okay, no hands go up. I mean, multiple physicians. Some of these, I just impressed that some of these patients still go to see physicians. They've seen so many, so of them. Medical care might not be coordinated, and that's regrettable. One of the things that we do the minute we're done with the consult, we call the doctors who are seeing that patient. It might be one, it might be four. Each one of them gets a phone call from us, because they're all going to get a copy of the bill, which they will have scanned or file a chart and not read. But the phone call helps try to coordinate that care. Iatrogenic injury is possible. Iatrogenically induced medical treatment. Failed back surgery syndrome. We all know patients who have had surgery who have increased pain. Sometimes patients are labeled crops. The overwhelming majority of patients that we see, I would not characterize as crops. Yes, there are a small number who have some other issues, but the majority are not. And chemical dependency may occur. You start writing, it's not so much addiction. Addiction is when you crave and you do things that you know will be harmful to you and still do them. But after a while, your body, even if you're not addicted, will become habituated to taking high-dose narcotics, and that in and of itself is a problem. And coming off cold turkey is not an option. You have to get on. By the way, who knows why it's called cold turkey? It's not narcotic. Okay, so who's heard the expression cold turkey? Okay, well heard. Because when someone abruptly starts a narcotic, they get goosebumps. It looks like a cold turkey, and that's how the expression came about. It's one of the signs that when someone abruptly stops narcotics, they will get goosebumps. It's part of the overall condition. And again, it looks like a turkey skin with the bumps. And the last thing is cost, of course, and that's right. Now, let's just talk about some of our common things. Muscular, soft tissue pain, facet joint pain, sacroiliac joint pain, cancer pain, nerve irritation, discogenic pain, and adhesion spine surgeries. In the spinal and back area, you have anatomic anomalies such as scoliosis, metabolic, osteoporosis, infection, inflammatory disease, cancer, trauma, degenerative disease, referred pain. So in other words, the pain can be referred to the back or vice versa. And psychosocial, which again I want to stress is very low on the list. I'm going to spend a minute on the malignant neoplasm. Not so much that it's related to workers' comp issues, but because if someone has cancer, we'll see that patient sometimes, although the oncologists are really good right now, the oncologists are very, very good about treating pain. But sometimes when they get stuck, they'll send it to us. And one of the things that I use cancer as an example is when we get that cancer patient who has, say, back pain, we don't automatically assume that that pain is from the back. We're going to do a full exam, and they can have a herniated disc causing back pain as well as you or I. And it's so a similar analogy. Let's talk about any pain, a non-cancer pain. If they come in complaining of a pain in a certain area, we're going to examine their whole body relevant to the points where that pain can be referred. And I'll get into some examples of that in a minute. Myofascial pain syndrome. The diagnosis is by physical exam history. You have to palpate a knot or a marble or a ropey band of muscle under the skin. It's not just if you press, oh, it hurts. That's just muscle strain or muscle pain. Myofascial, there's a marble or a ropey sensation under the skin. And one of those things I wanted to point out to you, for example, is you have pain going down an arm. In this case, it's the patient's right arm. If it was a left arm, would of course they have a heart problem as well. So when a patient comes to us and says they know that we treat a lot of spine problems, a lot of pain problems, we're not going to rush to say that this is a herniated disc that's pinching a nerve going down the arm. If it's on the left side, we're going to ask them if they have a workup by their internist for any heart trouble. right side is probably less likely, it's hard. But there's a muscle, I don't expect you to learn the name or remember the name, but the concept is the serratus posterior superior is just one of many muscles that refers their pain. So in other words, there's a problem in a muscle right by the shoulder blade, the upper part of the shoulder blade, but it's referring pain down the whole arm, just like a herniated disc or pinched nerve would do in other medical conditions. So it's our job to not rush in and say, okay, this is wrong. We have to look at other causes for pain solution. Another issue is similar in the lower extremities. You can have referred pains down to the knee. And again, it's our job to look at these common trigger points, and when they come over knee pain, do an exam up and down the leg to make sure it's not some other structure, so we're not just focusing on the knee, which is what was the pain. Fluoroscopy was revolutionized pain management because when I first started, we did not use fluoroscopy very much, but now in recent years, it's used all the time for precision. Fluoroscopy is a low-dose X-ray, and it helps us precisely place our medication. It makes it increase the safety, the comfort, and get better outcomes. It's much better science. When we're doing some of these injections, to give you an idea of the volumes we're using, some of them might be a half an ml or a third of an ml. So a few drops right over a structure. Not that we're putting in a whole syringe full, because we're trying to precisely identify what the source is. If I put in a whole syringe full of a local anesthetic, like the dentist, that's an example, he's trying to numb your whole jaw. You're going to have a whole numb jaw. I'm trying to figure out which nerve, to use this analogy, which nerve is involved, not numbing a whole area. Okay, so there's a big difference there in when we're trying to precisely identify the source of the pain. For those of you who have not seen a C-arm fluoroscope, this is what a C-arm fluoroscope looks like. It's probably about 7 feet off the ground. The name is derived because it's shaped like the letter C. That's very like all C-arm. The tables that we use have no metal in them. They're all fiber carbon tables so that we can use a view, a 360-degree view with the fluoroscope without any encumbrances by metal. Cervical facet arthroplasty. I just talked about this again as an example of precise diagnostic technique. The facets are innervate the nerves in each of the joints in the neck. They can occur in whiplash injuries. Sometimes we have a negative MRI. Facet joint changes appear on MRIs later than clinical findings. Repeating, facet joint changes appear later on an MRI than clinical findings. What is a clinical test for facet joint pain? So if you bend your head backwards, you're loading those joints in the back of the neck. The joints are on the back. So if you load it backwards, and I know that some of you experience pain of doing this because as you get older, that's where arthritis creeps in. And if you look up and turn your head to one side and you have pain that's increasing, you probably have a facet issue. And if it's an early finding, that won't appear in the MRI. But clinically, we already know that arthritis is happening. Similarly, in lumbar facets, leaning back loads the facet, going to the side loads that side of the facet, and it helps with clinical outcomes. So we know that the cervical facets can refer pain. Just like we talked about a few slides back, a trigger point can refer pain to a structure a little distance away from it. Similarly with the cervical facets, you don't just experience a neck pain. I'm sure that some of you who tilted their head back felt pain maybe towards their shoulder, or if they wrote it, I don't even shoulder problem. You're right. Again, it's my job to figure out, is the pain in the shoulder, or is it from one of the facet joints? Now, you might wonder, how do they know? How do we know, for example, that upper one, for example, it says C2, C3, for those who can't see it in the back. How do we know that C2 through C intervenes to the area? Well, we know that because, like most of you in college who are working your way through school, they found nursing students and medical students who needed cash. And they said, well, stick a needle in your neck and you tell us where it hurts. God bless these nursing students. Because that's how we have these data. You know where each joint is now refers pain, and it's valuable, and we still use these studies to this day. I'm not going to get into it, but and there's a pathway that goes up to the spinal cord, up to the brain that mediates pain. When we see sometimes on an MRI that there's not a big herniation, but the patient clearly has radicular pain or a sciatica pain, or pain going down their arm, why is that? Because as you see in the top left there, there's prostaglandins that are flowing. So even if there's a fissure, that nucleus pulposus has something that's as irritating as battery acid, so caustic, will leak out onto the nerve, and they're called prostaglandins, prostaglandins, but that's what causes the pain going down the leg or the arm, even though there's not a big disc herniation to push that nerve, but there's a leakage of this very caustic. Now, just review briefly some of the anatomy. There's an epidural space. Epi is Latin for around, dura is covering, so it's the space around the spinal cord. So when someone says I'm having an epidural, the epidural space starts in your skull and goes to your tailbone. It's that space around the spinal cord. So it's a long area. The intrathecal space, again, we just talked about terminology, is where the spinal fluid is. The dura is the covering of the barrier between the epidural space and the spinal fluid and spinal cord nerves. There's a dorsal root ganglion, which is right outside the spine. There's the facet joints that we've talked about. There's the nerves that lead to those facet joints. And as you can see, these structures are what? They're close together. So if we're trying to precisely identify it, we have to use small amounts of medication. Otherwise, we don't know what we've injected. The sympathetic ganglion, for those who have sympathetic reflex dystrophy, that's located in front and to the side of the spinal, of the vertebral body. There is a connection, though, between sensory nerves and sympathetic ganglion. Annular fissure, that's what we just talked about. So you can have pain without herniation because if that nucleus pulposus does what? If it leaks out, that's going to, on the nerve, it's going to hurt like that. And then a disc herniation, if it actually pushes out, a physical force, that's going to hurt. And compresses the nerve. Just a brief review, the aorta doesn't supply a lot of little arteries to the spine. You might think that the spine has a tremendous blood flow. It does not. It gets enough blood flow, but there's not a lot. If you ever look at an actual radiograph, this is what a nerve epidural injection will look like. You see an outline of the nerve in black, but the contrast side of the injection is clear, it just shows up there. And you can see the nerve root in that section, and that's where the medications are deposited in the big red blue. So, facet joint. You can have hip and buttock pain, cramping to the lower extremity, low back stiffness. You have tenderness, pain and extension, remember we talked about, where you lean back the waist, so pulling your head out in the neck. And you're not going to have a sciatica, it's just going to be located to your back down to your knee, or perhaps your neck down to your elbow. It's not going to be going all the way down to your fingers or toes. We use small amounts of medication, just like in the neck, to help identify which of these joints are in question, and then treat them. Sacroiliac joint pain, very similar. We will do physical exam. And one thing I want you guys to remember is the sacroiliac joint. When you look at an x-ray, the sacroiliac joint or lower back, you just see bones. But I want to direct your attention to the center of this slide. There are huge, thick ligaments between the hip bones and the sacrum that connect those structures. So if there's an injury sometimes in that area, and how do these injuries occur with the sacroiliac? We've all seen them.